According to the Center for Disease Control, about 100,000 people die yearly from pulmonary embolism, and 1 in 4 of those who develop pulmonary embolism die without warning signs. Pulmonary embolism is a life-threatening condition characterized by the obstruction of the pulmonary arteries by blood clots. It occurs when blood clots travel from deep veins and obstruct blood flow to the lungs. Septic emboli and, in rare cases, fat cells, tumor cells or gas can also cause pulmonary embolism. The process of clot formation includes venous stasis, blood vessel wall injury, and hypercoagulability. This is known as Varcho's triad. Shunting of blood away from underperfused areas of the lung starts when an embolus obstructs pulmonary blood flow. Significant shunting of blood away from underperfused areas to overperfused areas of the lung results in respiratory failure. This phenomenon is known as ventilation perfusion mismatch or VQ mismatch. Examples of acquired hypercoagulable states include pregnancy, hormone replacement therapy, use of oral contraceptive, malignancy, inflammatory conditions such as inflammatory bowel disease and systemic lupus erythematosus, antiphospholipid antibody syndrome, myeloproliferative disorders, and nephrotic syndrome. Examples of inherited hypercoagulable states include mutations causing increased activity of factors that promote clot formation, such as factor V Leiden and prothrombin gene, as well as mutations that cause deficiency of naturally occurring body anticoagulants, such as antithrombin 3, protein C and protein S. Infections such as HIV and COVID-19 increase the tendency to form blood clots. Genetic disorders such as polycythemia rubra vera and sickle cell disease can also cause pulmonary embolism. Factors that promote venous stasis such as immobilization from paralysis, fracture, major trauma or infection, post-operative recovery, obesity, sedentary lifestyle and long-distance travel with travel duration exceeding 4 hours can significantly increase the risk of developing pulmonary embolism. Clinical features include shortness of breath, hypoxic respiratory failure, tachycardia, pleuritic chest pain, cough, and hemoptysis. Massive pulmonary embolism can cause syncope, right heart failure, hypotension, and persistent hypoxia despite supplemental oxygen. Serum D-dimer is elevated. A negative D-dimer result rules out pulmonary embolism or deep venous thrombosis. Chest radiograph may demonstrate peripheral wedge-shaped airspace opacity from lung infarction described as Hampton hump, or regional oligemia described as Westermarck sign. Duplex ultrasound is the preferred test for DVT diagnosis. Urgent pulmonary CT angiogram is the gold standard test for pulmonary embolism diagnosis. Ventilation perfusion scan can be performed in situations where pulmonary CT angiogram is contraindicated, such as renal insufficiency and severe allergic reactions to iodinated contrast. A negative ventilation perfusion scan excludes pulmonary embolism. Echocardiogram may demonstrate bulging of the interventricular septum into the left ventricle, normal motion at the apex with absent motion of the mid-free wall known as McConnell's sign, dilated right ventricles, tricuspid regurgitation, and prominent proximal pulmonary arteries due to pulmonary hypertension. Individuals with acute hypoxic respiratory failure should be placed on supplemental oxygen or mechanical ventilation, if indicated. Vasopressors such as norepinephrine are indicated in those who are hypotensive. Anticoagulation therapy should be started if there is no significant contraindication such as acute intracranial hemorrhage. Unfractionated heparin or low molecular weight heparin known as enoxaparin is usually started in the acute setting with subsequent transition to oral anticoagulant prior to discharge from the hospital. Low molecular weight heparin is the preferred long-term anticoagulation therapy in patients with malignancy and during pregnancy. Example of oral anticoagulants include vitamin K antagonists such as warfarin and direct-acting oral anticoagulants. Warfarin is easily affordable, however, it requires heparin infusion or low molecular weight heparin until INR is in the therapeutic range of 2 to 3, for at least 24 hours when starting. Treatment with warfarin requires frequent monitoring of INR for proper titration of warfarin dosing. Anticoagulation therapy usually lasts for 3 to 6 months for individuals with known triggers such as long-distance travel. Patients with persistent risk of pulmonary embolism will require treatment for an extended period until the risk is eliminated. Patients with unknown triggers or those who are permanently at risk should be on anticoagulation therapy indefinitely. Direct-acting oral anticoagulants such as rivaroxaban, edoxaban, apixaban and dabigatran are expensive. However, bridging with parenteral anticoagulants when starting and frequent INR monitoring are not required. Systemic thrombolytic therapy with medications such as alteplase and tenecteplase might be necessary in those with hemodynamic instability due to significant clot burden if there are no contraindications. Systemic thrombolytic therapy is contraindicated in those with prior intracranial hemorrhage, intracranial malignancy, evidence of aortic dissection, ischemic stroke less than 3 months, recent neurological surgery involving the brain or spine, and active or high risk of developing hemorrhage. Catheter-directed thrombolytic therapy or catheter-directed embolectomy can be performed by interventional radiologists or vascular surgeons if indicated. Preventive measures such as early ambulation and prophylactic anticoagulation should be encouraged after surgery or during hospital stay. Mechanical compression devices are appropriate if prophylactic anticoagulation is contraindicated. Inferior vena cava filter can be inserted if anticoagulation therapy is contraindicated.